Hi, everyone. Welcome to another episode of our podcast, The Animal Heartbeat. My name is Jose Novomatos, and I'm here with my partner in crime, Kieran and Jose. And we'll be talking today about prognostic factors in myxomatous mitral valve disease. As you know, mitral valve disease is the most prevalent heart disease in dogs, and determining disease severity and prognosis is paramount for vets and clients. To quantify disease severity is really important to decide when to intervene. And until recently, we were mainly dealing with medical treatment and when to start medical treatment. But recently, or in the past 10 years, maybe, surgical mitral valve repair became a very important option, with two highly experienced centers in the UK offering surgical repair. Most recently, an hybrid transcatheter mitral valve repair procedure has been developed by the Colorado State Group, and you, Kieran, have been among some of the first ones doing this procedure. So what are your thoughts about the importance of quantifying disease severity?
I mean, it's incredibly important, isn't it? It's just so common. I think the figures from the Vet Compass group at the RVC a couple of years ago, looking at just left apical heart murmurs prevalence in primary care practice, estimated that mitral valve disease affects about 1 in 20 dogs, so 5% of dogs. But that was including all breeds and sizes and body weights. And actually, if you look at those smaller breed dogs, it's far more common than that, isn't it? And certain breeds, of course, the poor old Cavalier in the UK at least is the sort of poster child for mitral valve disease. And on necropsy evaluation of Cavalier valves at age 10, 100% of them had some degree of myxomatous change. Now, that doesn't mean, of course, that they've all got murmurs at age 10, but it just gives you an idea of how common it is in those older dogs. And I think, I commonly see it in dogs of 3, 4, particularly in Cavaliers. What's your youngest Cavalier, do you think, you've ever seen with meaningful myxomatous changes on the mitral valve?
The classic figures would be middle-aged to elderly dogs.
Yeah, it's true.
Those are the classic figures for myxomatous mitral valve disease or significant myxomatous mitral valve disease. So the disease has an age-dependent penetrance, if you want, or is more likely to develop as dogs get older. But I think I would say 5-6 years. And then what is very tricky and maybe beyond the scope of this episode, but maybe still interesting to touch on it, is when you have very soft murmurs or you do not have a heart murmur, and then on echo you find already some signs of valve disease.
It's a tough one, isn't it, to know what to do with that?
Yeah.
I mean, I think I tend to say just wait for a murmur. And treat it like any other dog. But it's difficult because there's a disease present even when they're very young. I did a bit of breed screening in Cavaliers a few years ago. I got sort of quite interested in it since my interest has waned a little in the breed screening side of things. But it was very interesting because I would commonly see dogs with some degree of mitral prolapse at even age 18 months or 2 years in the Cavaliers, which I was quite shocked by. But obviously some of those dogs will have some degree of mitral prolapse on echo, and they won't get a murmur till they're 7, 8, 9, 10. So it doesn't, echoing them that young, I don't think is important necessarily prognostically. I think for breeding, sure. And actually very important for breeding and probably more useful than echo in youth is something that is a really underestimated prognostic factor, I think, for mitral valve disease, which is family history. There's a lot of good data out there from, years ago now, 30, 40 years ago, showing that dogs whose parents had murmurs younger also had murmurs younger. So therefore, not only is the disease inherited in particular breeds of dog, a lot of research is in Cavaliers, of course, but it's not just Cavaliers. It's going to be the same genetic basis or a similar pool of genes that's causing it. But not only was the disease inherited, but actually the severity of disease, the age of onset was inherited. So if we have a dog whose parents were both dead by age 6 because of heart failure, even at age 1, I'm worried about that dog. I'm worried about the future for that individual. And I think that's a really important prognostic factor, perhaps one of the best we've got for long-term prognosis. Unfortunately, it requires family history. And most owners of pet dogs, Cavaliers, whatever, don't have that family history. They have something from the breeder saying, yeah, everything's fine. It's challenging, isn't it? I don't know what your experience is of these dogs, or of cats maybe as well, because that's a similar thing, isn't it?
Generally, we don't have a lot of family history. Yeah, this will be a tough disease, again, in terms of genetics, family history, inheritance, because it's clearly a polygenic disease.
Yeah.
So many environmental, epigenetic factors are likely to play a role. But agreed, family history is an issue. But as you were saying, age of onset is important. This disease has a very, very long asymptomatic, subclinical, preclinical stage.
Yeah.
Which I think is useful for the clients to understand that dogs remain in stage B1 for many, many years. And
60% of those dogs in B1 never develop signs of heart failure.
Exactly.
All that Borgarelli work, which, a lot of what we're going to be talking about today is based on Borgarelli's longitudinal studies. And that's fantastic stuff. That observational natural history of disease is super important, isn't it?
Yeah.
This is where the philosophy that some vets have of, if there's a heart murmur, I'll give it vetmedin or pimabendan because it's better to be safe. Well, oftentimes, if you do that, 60% of your treatment's unnecessary, isn't it? Exactly. And that's a challenge for me. I don't agree with that.
Yeah, absolutely. And exactly. And to communicate that to the client and to discuss that is really important. So that means that, you detect a heart murmur. And then if you have the classic breed, small breed, medium breed size dog, middle-aged to elderly, left apical murmur, that means in the large majority of cases mitral valve insufficiency caused by myxomatous mitral valve disease. So if the patient has no clinical signs, this will be a stage B dog. And then the big question is it B1 or B2? We need echo and or x-rays. What would be your comments on that? Would you echo, if a vet cannot do an echo, would you still rely on x-rays to define B2? Do you always want to have an echo? What's generally your approach?
I think radiographs are better than nothing. There's some of the work from Sonia Gordon's group at Texas A&M has shown that if you have what I would call quite significant cardiomegaly on a radiograph. So they were looking at two things. They were looking at vertebral heart scale, VHS, which has its own challenges in measuring. But they were looking at VHS of 11.5 or more being suggestive of stage B2 myxomatous mitral valve disease. And that seems reasonable to me. I would say that many of these dogs are not quite as big as that to be associated with stage B2. But echo is more sensitive, of course. So we're used to using echo and we'll pick up those earlier cases. The other thing that they were looking at was vertebral left atrial size, which, if any of the listeners out there aren't familiar of it, we'll tweet a picture this week of how to measure vertebral left atrial size and VHS. But I quite like the VLAS because it's only one measurement, whereas the VHS is two, and therefore you have compound error affecting it. The vertebral left atrial size is reasonable. I mean, it's not perfect, but it's reasonable. And if the vertebral left atrial size was 3 or more, that was more suggestive of stage B2. So I think those are reasonable ways of looking for B2 on radiographs. And echo is always better, though. And you can learn to echo that, that there are protocols for training people to echo, which, are shown to work nicely for people to learn how to measure left atrial and left ventricular dimension. And actually in the consensus statement on mitral valve disease, the authors there talk about using a combination of echo and radiographs, which is what the EPIC criteria were. But actually, most of us don't bother using the radiographs. I think most of us would just rely on the echo because we know that the echo is sensitive enough to detect those earlier cases and doesn't require the sedation that maybe a radiograph does, although not always. I think that the problem with echo is that sometimes we find a dog where, the left atrial size might meet the criteria for stage B2, but the left ventricular internal dimension doesn't.
Yeah, I wanted to ask you that. How do you approach those cases? So let's just to remind everyone, so the EPIC criteria for stage B2 or LAO more than 1.6, and the left ventricular internal diameter, normalized left ventricular internal diameter, 1.7 or bigger. And as Kieran is saying, many of us will see cases that one of the criteria is met, but not the other one. So what's your approach on those cases?
I used to give them the benefit of the doubt, if you like, and I would say, this dog is B2, albeit early, and I would start pimobendan treatment. But actually, I've changed my approach now through working with colleagues who've been more rigid on those criteria. And actually, I agree that the EPIC criteria, they weren't very conservative. So they may have detected some dogs who were at the very start of progression. Now, I'm not saying that doesn't mean we shouldn't use those criteria. I believe we should to decide to treat with pimobendan or not. But there are certainly some cardiologists out there who really strongly disagree with the criteria and think they're too lax and that we're going to include lots of dogs who don't need treatment. I disagree with that. I think when we look at the EPIC data, we can see that whether the criteria are a little bit liberal or not, those dogs have a clinically significant benefit over time. So I would say that using those criteria from the mitral valve consensus statement is appropriate. It is what I do, but I do use the criteria. So now I am more strict with myself and my decision making, and I will use left atrial to aortic root ratio combined with left ventricular internal diameter in diastole normalized to body weight. So I use those two. In addition, if I've got a borderline case, I will also use the two-dimensional measurements of absolute maximum left atrial diameter in long axis and LVID in diastole in long axis from a 4-chamber view, and normalize them for body weight as per the Lance Visser paper from 2018. I think that's a great reference for echo values. Yep. And I use that a lot. If I've got borderline cases, I look at it and go, well, if Visser's criteria say that this is within reference, I'm not going to treat. If Visser's criteria say that it's over the reference interval and my LAAO or the LVIDDN is large, then I will treat. So I use the Visser criteria. Now, they weren't considered in the consensus statement, which is fair, I think, because the consensus statement was really aimed at non-cardiologists. It's aimed at interested vets who are performing echo, vets in primary care practice, to help them make good decisions about a large population of dogs. I don't think the consensus statement works for every single case. And I'm sure that you and I will use it as a vague guideline and we'll make our decisions based on other criteria as well, not just those one-dimensional measurements of a complex 3D structure.
Exactly. Yeah, that's a good thing, and that you mentioned that, and we'll discuss that maybe a bit later. Mm-hmm. Because how much shall we, or what's the danger to rely on just a one-dimension measurement? The guidelines are recommendations and will never be the Holy Bible.
Absolutely.
And that certainly has not been the aim of the authors. And so, as you're saying, they work as guides, as a guidance. And especially for vets with standard of care echo abilities, and also for specialists to use as guidance, and then you need to adapt to your case. So, but that's great. I agree. So I'm strict, let's say so, and I want both criteria to be met before starting. Let's say in this case, pimobendan, especially because I don't think there's a huge urgency.
I agree with you. When they're on that borderline, they've got years, exactly. Right? Yeah, exactly. In most cases.
Exactly. And so that's great. But now this brings us to another point. If then we are doing echo, and most studies have shown that the best prognostic factors and are echo variables. And so can you comment on that? Which factors do you look on echo that help you determining how bad is the disease? Or let's say if we are talking about subclinical, preclinical, as you prefer, disease, which factors, which echocardiographic factors you use to determine and assess what's the risk of these dogs to develop congestive heart failure or the overall outcome?
The real challenge is the preclinical dogs. The stage B dogs, or stage B, well, B1 and B2 actually are important to think about. Once they're in stage C, once they have clinical signs of congestive heart failure, well, their prognosis is poor. The median survival time is between 9 and 12 months, depending on the breed and other things. So I will use that figure to talk to owners about this. They've got an idea of the fact that the prognosis is poor long term, without sort of a major intervention, some sort of surgical intervention for those cases. And it is, of course, the minority of dogs who go for surgical intervention because access to surgical facilities is limited. In the UK, we're super lucky. We have 2 centres doing, mitral valve repair on the pump, on the bypass machine. And we have another centre doing transcatheter edge-to-edge repair. So we're very, very lucky to have access to those facilities. The problem is the cost. Surgical repair in the UK costs between 15 and 20,000, and the transcatheter edge-to-edge repair is actually around about 12,500, something like that. These are expensive procedures. I think because of that, we need to really think about this as a big population disease and think about what most dogs will receive, or what care most dogs will receive, which is medical therapy and monitoring. So going back to the echo is super important, obviously. And I think once we identify them as solidly in stage B2, so they've got a left atrium aortic root ratio of 1.8 and an LV IDDN of, 1.9, 2. Okay, they have a worse prognosis. We know that their survival time is shorter because they have a bigger heart. There's a lot more nuance than that, though, because of the nature of these measurements. They're quite blunt tools. And what they're doing is they're looking at the secondary effects of the mitral regurgitation on the heart and RAS activation, etc., on the heart. They're not looking at the regurgitation itself. So in humans, they don't really look at heart size as a primary measure of mitral regurgitation severity. They will use MRI to quantify the mitral regurgitation severity. In many cases, or they'll do things like measure your left atrial pressure based on catheterizing the pulmonary arteries and measuring a wedge pressure. So obviously we could do that, but we'd need to anesthetize our patients. They can do it in conscious people. We need to anesthetize our patients for that. And that immediately makes that, A, expensive and challenging. B, it makes the pressures change. So in a conscious animal, the left atrial pressures will be very, very different to an anesthetized patient. So it's one of those sort of rules where actually trying to measure it for us makes it abnormal. So I think echo is what we are left with, and trying to estimate mitral regurgitation severity on echo is really, really hard. I've become much more interested in this in the last couple of years because we were working on this mitral surgery program, and because now we're in a situation where we have got other centers that we can refer to do these advanced procedures. So I like to be able to make an assessment of them and say to an owner, look, your dog maybe doesn't have the largest left atrium yet, but we need to be planning and thinking ahead because its regurgitation is very bad.
Let me just stop you there for a second.
Yeah.
Because you're bringing very, very interesting and important topics. So just to summarize, the ACVM guidelines define the disease staging based on one-dimensional measurements of chamber diameter, LAM, sure, left ventricular diameter. And as you were saying, these may not be sensitive enough to detect different severities of mitral regurgitation, because we are looking at the secondary effects of mitral regurgitation. Again, in the defense of these methods, they are easy to use. They are simple, efficient.
They're accessible, aren't they? A lot of people can do it.
So it makes a lot of sense that they were used in very large clinical trials.
Yes, definitely.
EPIC, the Quest. So that makes a lot of sense. Protect one-dimensional measurements makes a lot of sense. But now, more recently, as you were saying, in humans, they quantify LA volumes, LV volumes, and they try to quantify, or they quantify regurgitant fraction. And in the past few years, there have been at least two very interesting papers, one from Dr. Oyam at the Pennsylvania group on quantifying mitral regurgitant fraction in subclinical disease, mitral valve disease, and now more recently from Lance Visser at Davis at the time. And so there are different ways to quantify regurgitant fraction, but the methods they suggest, the volumetric methods, are not that cumbersome.
No, I think the two main methods that are used are a method called PISA, or rather PISA-based methods of quantifying mitral regurgitation severity. So PISA is a proximal isovelocity surface area, and we need a really good color map on the valve. We need really nice settings on the machine. We need just great angulation, looking at the coalescence of that flow on the ventricular side of the mitral valve. And what happens is actually, before it sprays through the orifice in the mitral valve, the velocity is the same in a sort of hemisphere of flow. If anyone's brain is melting now thinking about that, well, fair. It took me a long time to get my head around this, but basically it's a phenomenon of physics. So the blood sort of queues up to go through the hole, and as it queues up, the speed in that area is the same. And you can quantify that speed by looking at color maps. And basically you look at the area of the color map. So you measure the PISA, and that gives you an estimate of the orifice size in the mitral valve. And then, of course, from there, you need to do that and add some other measurements, some Doppler-based measurements, VTIs and mitral regurgitation and volumes and things. And actually, then you can come up with an estimate of mitral regurgitation severity. So you can estimate something called regurgitant fraction, which is how much blood is going backwards of the dog's stroke volume. So, if the regurgitant fraction is 50%, then 50% of blood from the left ventricle in systole is going back into the left atrium. 50% sounds like a lot, but a lot of dogs are much higher than that in advanced disease. The other way of estimating that.
When you start measuring and you realize that 50% of the total stroke volume is being pumped backwards.
Oh, it's mind-blowing.
Isn't it? It's like, it's huge. Because you look at the left atrium is big and so on, but when you start realizing how much blood is being regurgitated, it's crazy, isn't it?
No wonder the left atrium is huge.
Yeah.
The other method of doing it is to, since we're thinking about volume, just measure volume. So you can estimate forward stroke volume. You can, look at the stroke volume of the left ventricle using 2D planimetric methods, and you can look at transmitral flow and things, and put that all together and use those without using the color maps to get an estimate of regurgitant fraction. Personally, I think the volumetric methods are probably more repeatable. Certainly in my hands, they're more repeatable. Well, in the past, when I've shown my residents how to measure PISA, they've just laughed at me and said, well, how do you know that's the right time? And I said, well, I don't. I just think it is. And if everyone thinks it is at different times in the cardiac cycle, then, of course, it's just a random number generator. It's very settings dependent. It's very angle dependent. PISA is a problem when there are two jets of mitral regurg, which is not infrequent, and you have to get the sort of just the right angle to catch that on your echo. Otherwise, you may miss secondary jets. You may get an abnormal shaped PISA. I think it was the group from Liverpool a few years ago published a paper on PISA where they were talking about it and looking at repeatability. But actually, one of the problems is that PISA can change throughout the cardiac cycle. So, of course, you have to look at maximum PISA. But who knows what that is? It's very challenging. It's very challenging.
Much of our prolapse may also affect PISA and the hemicircle and exactly change across the cardiac cycle. So incredibly challenging to do, and you have to play with the Nyquist limit and so on. As you were saying, it shouldn't work as well in eccentric jets, which is what defines the disease. And
especially in early disease, the jets are eccentric, and as the heart becomes dilated, you get more central looking mitral regurgitation jets. So PISA is better probably in more advanced disease, but that's not when you want it. You want it in the early disease. You want to spot the dogs that are going to dilate and are going to get secondary change. And that's so using PISA when it's at its most accurate is probably when it's at its least useful, I think.
Absolutely. And then I think that's exactly why I don't think it became a widespread use technique, because it was quite many years ago. So I think
they use it in humans.
Yeah, exactly. What I think is very exciting, as you were saying, are the volumetric methods, because in fact they do not require any new measurements, or are based on measurements that we all routinely do on echo. But having said that, as you were mentioning, there are two ways to quantify volumes. So the initial work from Pennsylvania just a few years ago calculate volumes using the prolapse ellipse method, where you basically cube the minor axis of the left ventricle. You determine the left ventricle diameter in systole and in diastole on M mode, and then you raise that value to the power of 3. And this is similar to what the Tycholk's method uses, if you want. And it has been shown that as the ventricle dilates and loses its normal ellipse shape, then these assumptions are lost. This way of determining volume will overestimate the volume, because the ventricle becomes more of a sphere and is not an ellipse anymore. Having said that, it makes sense that this group did these assessments using linear dimensions, because this is very easy and quick to acquire, and our measurements that people are already acquiring. So it makes a lot of sense. But then later on, the Visser group used the Simpson's methods. So you were saying you would generally use the modified Simpson method of discs.
Yeah, exactly. To use the volumetric. So I do a planimetric based method. It's a problem, isn't it? Because with all these studies, if one person gets good at it, their repeatability gets quite good. and their intra-observer variability gets quite low. It's when different centers are doing it, and they may have learned differently, they may have trained differently, they may have a different approach slightly, and therefore, of course, comparing results from one center to another is not necessarily very easy, but probably not that important in clinical practice. It's more important.
That's a very good point. That's a very good point. And people should stick to the method that they are more used to.
Right.
And then what makes their workflow better when they are scanning patients, which measurements they acquired. And again, the data from Dr. Oyama would use M mode linear dimensions, which we will already be acquiring them when assessing internal diameters. So it makes sense.
I'm not a fan of M mode though.
Yeah. In general, I totally agree. I would use M modes. I think the only time I use M mode is probably for mitral valve disease.
Yeah, I think so too.
The EPI criteria used M mode, and so then
right,
I would use M mode. But I agree. And then the Simpsons method, just to be fair, also the Simpsons method is of course not perfect and requires a very good image quality. One needs to be certain that we are not foreshortening the left ventricle. So long axis views, you need to be sure that you have the whole left ventricle. Sometimes you have an apical dropout, or the left ventricle is foreshortened. So this will of course underestimate the volumes. So you will also require very, very good image quality. But I think the bottom line is exactly what you were saying. People should stick and train with one method and then use them. And the methods are not interchangeable, but then if you stick with your method and calculate regurgitant fraction based on always with your method, that would be useful. What is interesting looking, and I have some figures here from Visser's data, which raise a lot of questions. So when they determine regurgitant fraction in B1 and B2 dogs, and so B1 and B2 were defined based on the ACVIM criteria. Yeah. The regurgitant fraction in stage B1 ranged from 9 to 58%, and in B2 from 14 to 76.
Right.
That's the range. And this, of course, would tell us that some dogs that were B1 could already had severe regurg, and some dogs were classified as stage B2, the regurgitant fraction was not that severe.
Yeah.
And so, yeah.
You see, I think that's a temporal phenomenon. So that's obviously a cross-sectional study. So it's looking at, one point in time. Imagine you have a dog whose mitral regurgitation is not that severe, but it's had it for a decade. Well, it might have had prolonged RAS activation, prolonged increase in aldosterone, fibrosis of the heart, remodeling. So you might have not very severe MR, but a large heart, which would classify the dog as stage B2. But in B1, you might have fairly acute MR, a rupture of a minor chordae, quite bad mitral regurgitation, but the heart hasn't had time to stretch yet. So I think we can explain that from time and just the nature of the sort of heterogeneous nature of the population here that we're talking about. So I would sort of argue that what we need really to assess these different methods of looking at mitral regurgitation severity is longitudinal prospective follow-up studies. I mean, we're going to say that about everything in cardiology, aren't we? We're going to say it about feline heart disease. We're going to say it about interventional cardiology. We need follow-up in the same patients, not just looking at different patients at different stages of disease. That's not enough to understand the natural history of the diseases, really.
Agreed. And it is, again, as you were saying, it's a very important point. These are early days, and both studies were cross-sectional, and certainly these groups are working in longitudinal data. What is very interesting to speculate is how this could affect your intervention timing, how these affect when you start treatment.
Right.
And if we have longitudinal data that then will show that we will define B1 and B2 differently based on regurgitant fraction, or based on having a more holistic approach. Because of course it's naive if we just use LAEO and left ventricular internal diameter to define a 3D structure. So now we start having a more holistic approach where we add at least regurgitant fraction. How would that work if we combine these variables? How would that help you defining outcome, prognosis, and when to start treatment?
Yeah, I agree. I think we're in sort of an exciting time for mitral valve disease. If you'd asked me 5 years ago, I wouldn't think I'd be saying that. 5 years ago, I probably couldn't have cared less about the future of mitral valve disease. I said, well, there are some centers doing some surgery. We've got some pimabendan now. That's great. What are you worried about? It's easy to define stage B2. But you're absolutely right that there's more and more things on the horizon where, more minimally invasive methods potentially down the line of performing a minimally invasive annuloplasty. Maybe they do that in humans. Thinking about the number of centers doing bypass repair across the world, it is increasing. There's definitely, more people thinking about TEER, the TEER procedure. A friend of mine has just performed the first one this week, in fact, in Brazil. In Sao Paulo, so that's starting there. It's Claudio Busadori, as you know, is doing it in Milan. We were doing it in Bristol last year, and now a team in Birmingham are doing it in the UK, and more and more centers across the US. I mean, I don't know how many now, I've lost track. The big question with that is, what's the optimal time to intervene? And I don't know. My suspicion is the best time to intervene in those dogs with a transcatheter procedure is the day they go into heart failure. But that's unrealistic. And ideally, just a little bit before that, 2 weeks before they go into heart failure. So this is where the early assessment of regurgitant fraction is vitally important, because I don't think all dogs in stage B2 will benefit from the TEER. And some dogs in stage B2 are probably too advanced. Open heart surgery on bypass, they can do a lot more with the valve than you can with a TEER, and therefore they can deal with patients from very early to very late disease very successfully. But with the TEER procedure, there's a small window of opportunity, and this is why getting good at assessing mitral regurgitation severity, I think, will be really important. I think, Jose, now that we've talked a bit about assessing regurgitant fraction and what that might mean for dogs and for repeatability and decision making, we should probably split this episode of the podcast, because there's a lot to talk about with preclinical mitral valve disease and the prognostic factors. So I think if we wrap up this episode now and just tease that in the next episode, we're going to be focusing on better established prognostic indicators on echo for looking at dogs with mitral valve disease and deciding about monitoring and treatment of those dogs, rather than thinking about these more complex measurements of regurgitant fraction. So join us next time on The Animal Heartbeat. Don't forget to follow us on Twitter and on Instagram, both of which are at heartbeat_pod. Please contribute, please ask us questions, and be part of the community of listeners who are interested in veterinary cardiology. Thanks very much for listening.